And then the opioid line, guideline note 60, we would add and chronic.
Are we on the page now?
We are on page 18. Bottom of page 18, we're looking at the opioid guideline. We'll add our new line to this. We would add and chronic pain because this is opioids for conditions of the back and spine. And then there's not any change in sort of the acute, but we really need to have a discussion about this last paragraph where you see all the red and blue on the screen.
So that's page 19.
Yes.
Page 19.
No.
Yes. Starts on 18 and then goes down through 19.
I just want to think all the scribbly stuff is on 19.
Yeah.
Yes. So all the scribbly stuff is the staff attempt to come up with something. So we have to get rid of these dates because the way it's written right now, everybody has to be off chronic opioids, no matter, even if they're just brand new coming on OHP. So the proposed wording, and obvious, this is just because the only evidence I could find was that CDC thing about 10% per week. I put that in there as a starting point for discussion. Don't look so concerned, Kat. It's just a starting point for discussion. And then taper plans have to include non-pharmacologic treatments. And then if you have a substance use disorder that's developed, we do have treatment for that available. Or actually, it's included because we struck out available and put included because we've been discussing at the state about we're really trying to increase our access, but it may not be available.
Not always available, yeah.
Always available, but it's supposed to be. So the main thing I think to discuss is that most of it, which is just taking away all the dates, I don't think is really anything that you need to be worried about. I did say it needs to have non-pharmacologic treatment strategies, and then it's based on the back guideline. I just struck that because now we've got a couple different guidelines. So I think the main thing that we all need to talk about is what the taper should be. Part of the discussion we had at HERC in May was, do we want to say a year? Do we want to say 3 months, 6 months? There was discussion about not having a limit, just saying there has to be a taper, and they were very uncomfortable. They did not want to do that because they felt that then the taper might go on forever. So they want a limit of some sort, and they're looking to you to tell them what to do.
So I would advocate, given that there is no available evidence, I always hate making a recommendation based on expert opinion in the absence of evidence, but I would say to be consistent with the previous guideline, we gave a year. And so at the very least, it would be consistent with the previous guideline.
The previous version of the guideline.
Yes. Sorry.
And so that was what I had brought to them as the suggestion. And they had a lot of concerns about a year because they felt that was too long.
Yeah.
But you're shaking your head.
No, I know, but
You want to be successful.
you want it to be successful, and you can put something arbitrary like 10% a month or something. 10% per week.
That's so quick.
Yeah, this gets to the point is if you actually know what you're doing and you understand how to taper, like, so we have emerging evidence, and so there's going to be within the next probably 4 years, there's going to be evidence out of Stanford that Beth Darnell is doing long tapers with people, and finally what we've done anecdotally, you're demonstrating when you take people through this process, they can be very successful. But when you put it on like 10%, this is really, really fast when you're trying to get them off in like 2 or 3 months. I think at least a year is a good. You could get people off a year, especially if you know what you're doing and you can do it in such a way. It's a little bit more flexible because one of the things is when people get engaged in this and they start feeling really good, sometimes the patient wants to accelerate the taper. So then it gives them, rather than just saying 10% a month or whatever. So I really like that year date.
Is there a way we could indicate that that's kind of the outside end of things, that certainly things could be done differently?
So to end opioid therapy no later than 1 year? To end opioid therapy?
I mean, just to, that to understand that there's a broad range of how this could go with patients.
Some people can do it real fast.
But the expectation is that within a year you're done. Yeah. So if it's done fast, great.
What I would say from our experience is the way that we implement this is we would give 3-month periods. We would ask for a taper plan, and we would approve for up to 3 months. And then we check in. Because a lot of people can be successfully tapered in 3 months if they're not on those stratospheric doses, but you have to do the check-in. Because if you say, hey, we'll check back with you in a year, nothing will have happened.
Exactly, right.
So we could say an end-opiate therapy no later than 1 year from the start of the taper with reevaluation every 3 months? Or do we just say...
Ask them, but, you know, this guideline was in place when we had the biggest number of people that needed to be tapered. And I would check in with the medical directors, but I think that it's been pretty successful not spelling out the intervals in which you need to check back.
The reason we picked 1 year was very pragmatic for back, and it was because we knew that we wouldn't have the ability to taper everybody all at once, that there would have to be some people who wouldn't start their taper until 6 months into the time limit or whatever, just because of manpower. And so that was a very pragmatic 1 year. But I'm hearing from this group, you all are pretty strongly wanting a year. And I can take that back to the HERC. I mean, they were like, look at the evidence. There's no evidence. And I can say that you all, as the experts, really feel that that should be a year.
And then...
Up to a year.
Yeah,
up to a year.
Yeah, within 1 year of the initiation of the taper, and you get a gold star if you get done sooner. I mean, is there some way to say that?
What we found, so it's interesting because when we first put some restrictions around chronic opioids back in 2010, before we even had this guideline, and we had fewer appeals than we expected. For providers who had buy-in, as long as the provider had buy-in, the patients were largely successful. We had a lot of providers at that time who had no buy-in at all, and this was terrible, and how could we do this cruel thing? And surprisingly, their patients had a harder time. But unless there was a problem with hearings extending out additional coverage, I would leave it alone. I don't know. Holly Jo, what was your experience? Yours has been more recent than ours. Are you still there, and are you on mute?
Holly Jo, are you still with us?
I did hear somebody drop.
Okay.
Okay, so
sorry, couldn't get the phone unmuted.
no problems. So we were just asking what you thought about the 1 year from start to taper wording, and what your CCO experience was, if that would work for you.
I'm sorry, ask the question again.
Did you find that in the previous iteration of the opioid guideline that 1 year time frame to have people tapered off, was that problematic? Did you have a lot of people extending out and not tapering? And did you have any hearings where you had said, no, it's time to be done, and the hearing overturned you?
No. I mean, it was a year long. We notified all of the patients involved and all of the providers involved at the beginning of that year. And, early in the year, we gave people 3 months to submit a taper plan. If they didn't, then things were not renewed. And they all knew that, and they all lived with that.
Yeah.
And so if they had a taper plan and were actively working towards getting off, then they had their opioids renewed until they were off, or until the end of the year. We had very few exceptions that carried on past the first of this year. If they were still on a taper plan and still actively weaning, as long as the chart notes didn't say we're weaning and the fill history was that they weren't weaning, and that because you do see that sometimes, but as long as the fill history and the dosages were decreasing, we fill them until they're off. And we haven't had any hearings. There hasn't been any. There's been a couple appeals, but I don't know that those. I haven't seen any of them go to hearing.
Okay.
Okay.
So it sounds like everybody here wants us to propose a year. And I think since we've discussed it, I think bringing it back to the HERC, they might be more open to.
Like Laura said, up to a year rather than a year.
So it says no later than 1 year from the start of the taper was how the wording I put in.
Okay.
Can I raise one more other unrelated issue? In the first sentence there, it says, for patients receiving long-term opioid therapy, we took out the word covered. So you could have a patient who's paying cash for their opioid prescriptions. And then they would, come out to a CCO, and the CCO would need to cover. Is that okay? Is that appropriate?
It's a struggle. If it's somebody coming new onto the plan, I think it's an easier decision. We sometimes have people who have been on our plan who have chosen not to follow a taper plan, have elected to pay cash, and then as the cost of the medication goes up, they'll come back around and say, but now we want you to pay for it. And where we typically fall, it's infrequent that happens. Where we typically fall on our plan is if it means that the patient is moving towards a safer dose or a plan to get them off opioids, we may start covering to encourage that taper, knowing that if they decide to stop the taper and go back up, that we don't cover that increased dose. So it can sometimes be an enticement to get people to try.
You're facilitating.
Yeah.
Yeah, I guess you have three scenarios. You have one is the patient's coming from covered opioid therapy on another insurance plan.
Right. Mm-hmm.
Two is they've been paying cash.
Right.
Now the price goes up. And, three is, it's been covered under the plan because the plan hasn't been enforcing the rule or whatever. So I think we need to think carefully about how to address all of those, because as it's worded currently, that patient who has been paying cash would have an appeal right to receive.
But they would receive to a taper.
Right.
Yeah.
Okay.
So that's okay.
And then, so again, trying to think of what the practice implications are versus just the funding implications are. So what I'm thinking is if someone came into my office and did that, now you're relying on the specific clinician to have good clinical judgment there on how they want to facilitate that or not. And if someone comes in and they were using the medications and they were paying cash and for whatever reason, and then they're saying, this is expensive and I want to try something else, then I would want to use that opportunity to facilitate them on like a low, slow wean where now I can get them engaged with other things. So I think it's appropriate. It leaves some wiggle room in there for them to work with. Because the other part is if their clinician says they don't want to prescribe, then this is never going to come up to, it won't even be a funding decision anymore.
Right. You could also have a clinician who writes 2 prescriptions and you pay cash for one.
Yeah.
And that has come up.
Oh.
That does come up.
Yep.
And then we have used the guidance of the CDC and the statewide performance improvement project to say, we're not going to help you to practice outside the guidelines by paying for half of the dose.
And you see that in chart notes, or how do you know about that?
You can, typically you see it in the chart notes. Occasionally you can see it in the pharmacy fill history, and you'll see one approved form and one denied form. But if you check in with the pharmacy to see what was dispensed, you can sort of tease that out. But typically you see it in the chart notes. Patients will tell us. We get appeals that say, well, you used to pay for my 5 milligrams and I would pay for my 10 milligrams. And now you're not paying for my 5 milligrams anymore, and I want to appeal that. So it is possible that it can have some unintended consequences, and we may have to see.
But do those unintended consequences outweigh the actual perceived benefits for the majority?
Right.
As I said, that's where it kind of gets, there's always people, the outliers,
Yeah.
that are going to.
Yeah. And it has been a small number, and I don't think I've had any that have gone to hearing. I know that in appeal, when we talk to people and we explain the reason for the guideline is to have you on a safe dose, not to, split the cost with you. Yeah, I don't know.
Are you okay with the wording of that first sentence? For patients receiving long-term opioid therapy? Or do you want to continue to have uncovered chronic opioid?
I think that is probably the best wording.
The changed wording?
Yes, the
Okay.
current,
Okay.
for patients receiving long-term opioid therapy.
Did I hear
I'm
someone on
sorry,
the phone?
just saying for Rose, I didn't quite understand what the final suggestion was there.
So it's basically what is in your meeting material. So it'll say for patients receiving long-term opioid therapy. And there's just some kind of fine points. Basically, if a patient was getting opioids that weren't supposed to be covered under OHP, that they would, it now lumps them into this. It's a fine point, and it may or may not have any effect on anything.
Okay, so let me just ask this clarifying question. So, are opioids going to be covered for chronic pain beyond tapering down to 0?
No.
Okay.
Except
Well,
for
actually,
all the
yes.
wording above it. If you have an acute flare, for less than, so for up to 3 months.
So I have to say that gives me pause
3 months
Yeah.
is long.
because you could have a lot of acute flares.
No kidding.
So do you want to, we can work on that. So this was written a few years ago, and it was based on like the Washington State Workman's Comp, kind of what they were doing and things. Do we want to change something?
So is that which line is that? The chronic opioid treatment, the 3? Or I don't see an acute flare line.
Okay, so if you go back up to the top of guideline note 60, for acute injury, flare, or after surgery, for the first 6 weeks, you can have opioids with prescriptions limited to 7 days for short-acting only. You have to have failed something like an NSAID or acetaminophen first, and you have to be doing something active. For the next 6 weeks, up to 90 days, you have to have a documented improvement in function of at least 30% based on validated tools. You have to be doing something else active, and you have to verify that there's no misuse, either UDSs or checking the PDMP or doing something like that. And again, 7 days of treatment with the short-acting opioids only, and then after 90 days, there's no further. We can change any of that. We could put something in there like only 1 flare per year is covered. I mean, there's whatever you all.
The chronic pain line doesn't belong to this opioid guideline.
Okay.
Are you right, instead of for acute injury, acute flare of, just pull out the chronic pain part? Like, so for acute injury or after surgery?
So I think what Tracy was saying is rather than lumping this together, put in a guideline saying that for chronic pain, opioids are not covered. If you're already receiving long-term therapy, you get this taper.
Here's my concern. This is a pathway to creating chronic opioid use because when you have an acute flare, you can have 6 weeks of weekly prescriptions and then up to 90 days, and now we have somebody chronically on opioids.
I would pull out that language right. I would just leave it for acute injury or after surgery. I would take out acute flare of chronic pain because the way the language is and the dates that they're using is because of the risk involved with transitioning to chronic opioid therapy. We know that people after 7 days it increases their risk by like 0.6%.
It's really interesting. If you look at the graphs, by like 30 days, it's like
scary.
it's like a third of people.
And you certainly don't want to hit 30.
Yeah.
Really, the reason the CDC guidelines said no more than 7 was the huge risk at 3, and then when you hit 7, it went even higher. And if you're at 30 days, now we're like 90% likely to be on them at the end of the year.
Yeah, it's
So-
crazy high.
I would pull that. I would just pull out that acute flare chronic
So
pain.
for
out
acute injury or after surgery?
after surgery, because that's very specific to that. And what we're really talking about is an individual flare of a chronic condition kind of
Yes,
thing.
and actually, if we make that change, the other thing this does is if I have somebody with chronic pain who may be paying out of pocket for opioids, we see this, who's had a surgery, now I can have some parameters around their surgery. Even if the surgery is unrelated to their pain condition, this is an issue that comes up. It's most common with orthopedic surgeries because those are the people who have their orthopedic surgery and then they never get off their acute opioids because they were on opioids before.
Yeah. There's another study just came out on that.
So is this what we're talking about here? Treatment with opioids up to 6 weeks, up to 90 days?
So the very first, actually, I guess the very,
It's on the previous
very
page.
yeah, the very last sentence on the previous page, we're going to take out acute flare of chronic pain.
Bottom of page 18.
Yeah.
So that, right there. And then, actually, I think it says it a couple places in the guidelines. So we'll take out flare wherever it shows up.
So this is Amber Rose. I wanted to check if you want me to.
Yes.
My wondering here is for the people who have chronic pain conditions that do have flares, what is it that doctors are going to be doing to support them?
So they now will
Yeah.
hopefully have a bunch of things like PT or acupuncture or something. There's actually been some good studies that have come out in the last few months that increasing opioids during a chronic flare is actually harmful and shouldn't be done. And so if a patient comes in and says their pain has gotten much worse, they tweaked something, you really need to be offering a different type of therapy to get them through that acute flare.
We also want to make sure that therapy is accessible immediately so that they don't have to wait 3 weeks for an authorization to be approved.
Right.
So from your point of view, if we take out all of the acute flare wording and we just have acute injury or after surgery, that would be okay.
I think that will help significantly.
Okay.
Yep.
And the prescription does, in that section, does have to be approved every 7 days. So.
Including after surgery, too. 7 days.
There's really, really good evidence that you should never be discharged from the hospital with more than 7 days of opioids, even after like hip replacement or something. That you should be reevaluated. And, okay. I like that change.
Yeah.
Just note that will apply to back conditions, but I think that
I think it's
appropriate for especially with the newer evidence coming out about flares.
Ideally, also, the patient will have had the opportunity to see a behavioral health provider a few times and have better tools to manage those acute flares, or a physical therapist, or whoever they're going to support them through those flares.
Okay. Okay. All right. Any other changes that you want to do to that guideline? Being the experts on.
Did you want to discuss that table?
I know there's been. Oh, yes. I do want to. Thank you. Okay. So, I'm sorry. We're moving backwards now. Going back to the back and spine condition that we went through a couple of those easy changes. And then at the bottom, there's this table, which was based on a Chow review, which is quite old now. And it actually has things like benzodiazepines and opioids as indicated. So staff, I'm sorry, I should have highlighted this, I want to get rid of the table.
Oh, the whole table, or just the things that have been shown to be risky?
I'm not sure how much the table adds to the guideline.
Is the table directly from that study?
This is from the old Chow guideline. I think it was circa 2012, 2013, no, 2011. And then there's a new child guideline out more recently that may have an updated table. We could look at that.
That would be perfect.
Okay, so let me make some notes here. So look for new child study, see if table updated. And then if not, take out benzos, opioids, skeletal muscle relaxants.
That's only there for 4 weeks.
Yeah, keep that in there. Just take out the benzos and the opioids.
I know that there were 3 papers that came out from Roger recently that include the medication part, so.
Okay, so you're pretty sure that there's a new table.
I think that, I don't know about the table, but I know that there are definitely medication recommendations that were put out recently.
And this is for back. It's not for chronic
Right.
pain.
Mm-hmm.
So, okay. Okay, so I will do that. But you feel that the rest of the table is helpful?
I'd like to see the new ones.
Okay.
Or if there is a new one. Most of what we've talked about has already been kind of is in this table. This just puts it in a different format, but so if there's a new one, it'd be great. Otherwise, it would be pretty easy to update it. Consistent with
Yeah, because
what
we got CBT, but not necessarily ACTs not on the table either.
Yeah, and this is multiple years old. So, and I believe it was Kim who was really concerned looking at it at a previous meeting. So, okay, so it doesn't have anything to do with our new line, so we have a little bit more time for staff to kind of dive into whatever chow or whatever replacements we want to do. Okay, so we've talked about that. We talked about the opioid guideline. And then the last one is just a simple change to the acupuncture guidelines, since we're adding acupuncture as a covered service. It will be the chronic pain syndrome line. Acupuncture is included in this line with visit limitations, as in the guideline note on chronic pain therapy. If we don't put it in this guideline, then we always get this, it's not covered because it's not in the guideline. And the line will move. Since it's going to probably be about 430 something, it will be physically moved above the osteoarthritis line. But
I'm sorry, this is Nora. We are on the table. I'm catching back up from the table was from the low back pain table. Is that right on page 9?
yeah, we were just talking about it's really out of date, and we've made no decision about it. Nora, staff is just going to look up and see if Chow's updated this table. And then this is from his.
Okay, yeah, because it also says specifically progressive relaxation only, rather than mindfulness, that it could include progressive muscle relaxation. It's an odd call out.
Yeah, I think this is really out of date. This doesn't really have anything that we have to make a decision about for our new line, because this is specifically only for back and spine. But it will be on the things that we will. So if it doesn't get all fixed by the time we present this to HERC, we can fix it in the meantime, if that makes sense.
Yes.
And then the last thing that we were talking about was just a simple addition to the acupuncture guideline to just note that acupuncture is on this new line and that it has the limits in the guideline. And are you okay with that? Okay.
Yeah.
Wow. Guys, you have created a new line. So I know we have some public, and we can have a few minutes for you guys to testify. I just want to talk about next steps a little bit. So I have a couple of tasks that I need to do. I need to look at the fibromyalgia line and possibly make some recommendations to make it just chronic fatigue, and I can send that to you all by email. Oh, great. Now my email connection it froze. Connection interrupted. So I will look at the old line and see if we need to do anything, take the diagnoses out, etc. And then we've updated the scoring and we've done some fine-tuning of all the things. What I will do is I will send you all a final document that we're going to present to HERC with all of the suggested changes, and just so that you all can see them. And I know there's a lot of moving pieces, and just make sure you've all had a chance to see them. So I'll send that out to you soon. I'm planning on bringing this, since we've come to a conclusion, I'm planning on bringing this to the August HERC meeting, which I believe is August 9th. It's a Thursday. Anyone is welcome from this group to come. I will specifically invite Kim to give a presentation on fibromyalgia. My guess is that it will not be approved in August. They will have some things that they will want staff to go back to either come bring this group together to talk about or just to look at. If we need to bring this group back together, I anticipate that will probably be in September-ish. Our meetings after August are late September, I think the last week in September, and then we'll have a November meeting. But this doesn't actually have to get approved till March, so we have some time. So we'll introduce it to HERC, find out what their concerns are. Anticipate this group will meet one time in the fall. That's maybe 50-50. It depends on what they really want us to, what input they need. If it's something simple that I can just email you all, that can happen. If it's something more complex, I'm thinking maybe if they want us to redo that chow table or whatever, if there's something a little more complex that's maybe even outside of what we've been charged with the specifics. And we will obviously let you know after the August meeting and come up with a date and time. And then once approved, assuming they approve it, it will go into effect January 1st, 2020, because it has to go through all the actuaries and all of the legislative stuff and all of government. So we aren't fast. We're slow.
Change does happen.
Yeah, it happens slowly. But the other thing is that once this is known to be sort of our intent, a lot of times some change starts to happen in anticipation of that intent. So, any questions about those sort of next steps? Like I said, I will look at the main thing that may be a quote-unquote significant change is the old line and what we might do with the old line if it's just going to be chronic fatigue. And then if anyone has any, from the email, if anyone sees that I didn't capture what you all thought we had decided on or whatever, we can have an email discussion about that before August. Oh, goody, do I have? Oh, yay, the internet connected again. And let me see if I made any other significant notes. Oh, and fibromyalgia will go on the line, and I will do some work with Kim about fibromyalgia specifically. But I don't think that all of you all need to necessarily, unless you have strong feelings and want to jump in there. And we will talk to the hearing reps about the active massage, those types of things. Get rid of 528 or move it or do something with it. And then the table from Chow. Otherwise, I think we're pretty much good. Any other last thoughts before we have public?
Just if we're going to have a meeting as soon as we find out when that's going to be, let us know. Yeah, it's hard for me when it's only a few weeks to change my schedule.
Yeah, and we had wanted to try to get this, I really had wanted to try to get this for like the summer meeting. Because like the fall meetings, we have CPT codes and stuff, right, and then we just get mired down in other stuff. So I figured if we could bring this to August, which is usually not as bad a meeting, we probably will make probably the final decision will be like in January or something.
Okay.
So maybe I should add, if we do have future meetings, I am relocating and we'll have... I don't know what my job change will be. I may be contracting still with Advanced Health, but I'm actually buying a house this afternoon in Wilsonville, so very handy. And I'm happy to continue participating because my medical director brain didn't, just go away. Just to kind of see the task force through to the end. I can check with my employer, but I think that they would support that.
So even if you're not a medical director, you're a primary care provider. So I think we could continue to support having you on board.
Well, I think that's some continuity there, and that having both brains is super, super useful. I mean, I learn a lot every time I come to these meetings.
Mm-hmm.
And so it's nice to know when you say
You're-
something that sounds great, and then you're like, there's a whole bunch of implications.
Yeah.
Thanks.
You have no idea.
Okay.
And then you're like, what is state government? Ah! All right. So I know we had at least one vote.
I think